I don't hide this. I will talk to this as we go through this little class, but I am a proponent of the vent should go on every time. If you drop a tube, whether you're 2 minutes from the hospital or you're 20 minutes from the hospital, I personally believe the vent should go on every time. Part of that is just because you don't know what's on the other side of those doors. Once you come out of the ambulance and you go into the hospital, we don't know how long we're waiting. Are we diverted? Where are we going to be? During COVID, I'm sure we all sat in the hallway and bagged people or put them on vents and left them forever, right? But kind of the same thing if you were to use mechanical CPR, right? If you put a patient on a mechanical CPR device and you gained ROSC, you wouldn't take them off the device, right? You'd leave them on in case they arrest again. If you drop a tube, right? My personal opinion, and again, that's just my opinion, is that you should be able, or you should put the device on every time. And so for me, I'm going to try to give you tools to make this device as easy as possible for you to feel comfortable in doing that, right? My main reason behind that, guys, is that, ventilation is what saves your patient's brains, right? We do all that work and I know it's not very code related, we do all that work to gain ROSC. We do these things, especially in codes, even respiratory distress, right? We do all this work, we drop nebs, we do everything we want to do to try to gain all this traction. And I think it's a misunderstanding of how quickly all that can be lost when utilizing a bag, right? And so I just want to make sure that we're all on the same page here, that as I'm going, I'm not saying, hey, you're doing this wrong or anything. I'm just saying this is what I see in the field, and this is what I think will help benefit you and your patients, right? So we're going to skip over all the makeup of the device. I mean, again, you guys will go, 10-hour battery life, 11 pounds, durable, right? The whole nine. I think we all agree it's a cool device. It'll do what it's not going to break, anything like that, right? The question is, how do we fix the alarms? How do I make it easy enough for me to use? So I'm going to first turn it on, and we're going to go into invasive modes just so we can kind of do a refresher of the screen. What are we looking at? What do all these things do? I'll kind of trip some alarms, show you guys how some things react on the device, and then we'll go from there, all right? At any point, please stop me if you guys have questions, concerns. Don't let me, go down the road, and then if we get so far down there, you guys are just like, I'm not even going to ask. So again, start menu. We talked about this, adult, pediatric, invasive option. So if you guys show up and you drop a tube en route, whether it's a ET tube, iGel, King Airway, Superglottic, Rescue, whatever the case may be, you will select adult or pediatric. So again, we go down to 5 kilos. I'd be shocked if you guys have put a ped on this device since you've had it in your hands, right? So I know that there's always it could happen, but for the terms of conversation, let's assume that 99.99999% of your patients, if they have a tube, are going to an adult, right? So when you guys are using this device, you should think to yourself, if I've intubated this patient, I only have one option to go to. If this patient is breathing on their own, I only have one option to go to. So adult, I'm in control. Mass CPAP, they're breathing on their own. Those should be your first two kind of thought processes, right? If I'm breathing for them, I'm on adult. If they're breathing on their own, we're going to go to mass CPAP first. Now from there, you can move wherever, right? And we'll get more into that. But again, so we select adult. You know how the device works, right? We're going to plug this bad boy in or attach to our ET tube. Device is going to start breathing on its own, okay? Now again, that is assist control volume, 12 breaths per minute, 450 tidal volume, 1:3 I to E ratio, FiO2 of 21%, okay? So 5'10", 5'11", average male, lung protective setting based on 6 to 8 mils per kilo of ideal body weight, or 6 to 8 cc's per kilo of ideal body weight, okay? So the idea here, again, you drop a tube, whether you want to think, not even use your brain. This is why I kind of talk about why you should put it on always, because if you're 2 minutes from the hospital, this device or these settings will support your patient. Are they going to be something like turns the corner, right? If you intubate the patient and title says 65, I don't think you're going to turn a corner at 12 breaths per minute, 450 tidal volume when you're 2-3 minutes away from the hospital. Do I think that you could send them the other way by squeezing a bag 15 times for those 2 minutes at 1,000 cc's of tidal volume? 100% you can. PEEP of 10, right? You turn your PEEP valve up because you're like, oh, patient, the sats are low. Let me turn my PEEP valve up. I don't think you understand how much air that is when you continue, right? We think about where this patient was when we first got to them, right? All these things matter in terms of why should I give them this 2 minutes of you know, uh, antiquated breathing, right? So when I go through this, let's talk about a couple of things. Bold numbers, you guys control, you know that. Outline numbers are a result, right? So, and I apologize since we're recording, it has the recording thing there, so we have to look around that. But a couple other things we're gonna talk about, right? So AC volume, assist control volume, just so you guys know how it works, why, right? You get to set a breath rate. That's your bold numbers. So right now, bold 12, patient will breathe 12 times a minute, or excuse me, we will breathe for them 12 times a minute, no matter what, every 5 seconds, right? Above that, you can see it on the screen. Outline 12, patient's actual breath rate, right? So when I go and create another breath, that should change to 13. It will tell you what your patient is doing under sedation. Most of the time I see these are obviously transports where you were about to leave, got caught on scene for whatever the case may be. You already had drugs on board. They start to wear off there. Like heavy trauma MVAs where we've maxed out sedation and they're still spontaneously breathing under the device, right? Okay, you might see it there. But in theory, intubation goes hand in hand with proper sedation, right? So we assume if we've intubated this patient, most likely you guys are able to keep them sedated. If you ever see that your patient is all of a sudden visibly uncomfortable, right? This would be the first place I would send you. Is say, hey, you need to look at that and see what it says, okay? If it said 18, you say, oh, my patient's breathing 6 times under sedation, right? And in this mode, it's not, oh, they took a breath, so we only got what they were breathing, right? If they trigger a breath, they get the full size breath. So they're going to get 12 breaths at 450, and then they might take on 6 more at 450 as well, right? And so kind of breath stacking, right? We'll get into that later, but we all know kind of what that does to cardiac output, right? So as you go around the screen, right, alarm parameters, 25 and 8, right? We're going to talk more about this non-invasively, but I'll tell you, these are the same numbers you get if you go into your CPAP setting wrong. If you go into adult and then go over, you're going to get 25 and 8. If your patient was breathing 25 times a minute, they probably wouldn't call you to be on the ventilator, right? Most people are breathing 40 times a minute, so you guys are already getting cooked for that alarm the moment you put the mask on them, right? So what I would tell you when we talk non-invasive is I would tell you to go here, press this, and we're just going to turn that bad boy up. We'll even customize it for you. But no one in here, I think, needs the device to tell them my patient's breathing fast. You show up, I could bring 5 different patients in here. One could breathe 20, one could breathe 30, one could breathe 40. I think everyone in here could look and go fast, faster, fastest, right? The number is there, of course, helpful, but you guys don't need it in real time. So if we were to set that to say like 50, a number where you would really want to, hey, if they're breathing 50 times a minute, I'm just going to take their airway, makes more sense, right? Usable alarm, an efficient alarm, as opposed to an alarm that isn't really doing anything, right? If it goes at 40, I think everyone here probably silences it and then goes, let me keep on doing what I'm doing, right? So we can move that up so you don't have to deal with it. But that is why the device is screaming at you, is because your patient's breathing more than the alarm is currently set, okay? Now, any questions about that little piece? All right, so the other piece I would bring up in there is you see your IDE ratio 1 to 3, right? It's another reason why I say why would we always put patients on this no matter how far away we are. I'm your patient, right? I live 10 minutes from the hospital, right? I have a history of COPD. You show up, I already walk around a high-end title, right? I'm probably walking around in the 50s, right? Mid-50s, but let's say you show up and I'm at 70, right? Do we hyperventilate COPD patients? Right? Contraindicated. Is it detrimental to put excessive amounts of volume into COPD patients, right? The only way that we can really have our COPD patients breathe off gas is to what? Give them a longer exhalation phase like in real life, right? Can't do that with a bag. So if you're bagging for those 2 minutes, all of a sudden I get stuck in the hospital, in the hallway for another 5, 7. Now I'm just sitting here trying to make sure my guy is good. Next thing you know, I put 1,000 mils per breath into this patient over 5, 7 minutes, right? With giving them no ability to blow that gas off. What does that patient look like when they finally get a room? How much are they overcoming? And not because you're not doing what you're supposed to, but just because we're a bit unfamiliar. And that's what this is about, right? What I would tell you is, hey, if it's going to be 2 minutes, great. I could go down to my IDE ratio right here, crank this over to 1 to 5, and now instead of me making this guy take 20 breaths a minute, he's going to take the same 12, but I'm going to give him a 1 to 5 IDE ratio. So he's getting 5 times as long to exhale, right? Whether that's 2 minutes, 4 minutes, that is better for your patient because that is how their body breathes when they are upright. That is how they need. And again, we don't understand or we don't know what their last 72 hours look like, right? Probably look like them sitting in a recliner. I'll be fine, right? Then they finally call you when they're circling the drain, right? So this is, again, just kind of my points on why do we utilize this. So just by changing that 1 to 5, right? And I'll move it again, but if you look down here on mode, you see where it says I time. So right now at 12 breaths per minute, at a 1 to 5 IDE ratio, that 0.83, that's a time. My patient's getting 0.83 seconds to inhale, okay? They're getting 5 times that to exhale, right? So 12 breaths a minute, 1 breath every 5 seconds, right? So in a 5-second span, if they're getting 0.83 seconds to inhale, they're getting what? 4.17 seconds to exhale, right? They're getting 5 times the amount of time. So what that just tells you, it just gives you an idea. So when you can see it, right? Every time you move one of these numbers, you see how I time moves. Now as I start moving my breath per minute up, that number continuously changes. So it's always telling you how much time is my patient getting to inhale, right? This is the same thing you'll be able to see when your patients are breathing non-invasively. That number will also change. Yes, sir.
I know this is kind of a basic thing, but I don't think everybody understands that some of these settings change on a short hold and on a long hold. And you might want to push up the button. So you might want
Yeah, well, all these ones all these ones are just, if it's in the box, you're just pressing it. There's nothing in the box that you get to by holding. All the hold buttons are things you don't see. So these right here, I will show you. Those you have to hold to be able to change. But when we're just talking about moving like breaths per minute, I just want you guys to see this number and understand that as you move things, that number changes, right? So like for our COPD patients, that matters, right? If you think about where we were before, this is what we were when we turned this thing on. I was at a 1 to 3 IDE ratio. So look at the default here, 1.25 seconds versus when I went 1 to 5, our patient was down to 0.83, right? So we took almost a half a second from their inhalation phase and said, this is not where it belongs. Let's move it on the back end. Does that make sense to everyone? That is another piece as to why when we're like, man, I'm 5 minutes away, is it worth me taking the time to do it? Those are little things that in some of these patients can flip them over the edge, right? So above that, tidal volume, I believe you guys have ideal body weight cards, right? So you look at it, great, guy looks like he's 6 foot, change it. Tidal volume, obviously, more volume, more pressure, right? Less volume, less pressure. So obviously, very basic, but the bigger size breath you put into your patient, right, the more pressure you're going to create intrinsically. Above that, you're going to see the pressure box. All right, this box is important. It's the number one, I think, most important box on the device. I think one just for things you can do, look at, also provider safety as well as patient safety, right? This should be at least a box that makes you think, I'm going to use this device because I know if I screw up, I'm not going to kill old Jimmy, okay? So that's kind of why I think that's one of the people's biggest attractions as well. If I put this on, now I'm bringing in lung trauma, barotrauma. What if I kill this guy? I got to, you know what, let me just bag him. Right? Does this thing track data? I know my bag doesn't track data. Numbers, things, I mean, it is what it is. I get it. But so peak inspiratory pressure, right? The amount of pressure or the max pressure that you create at peak inhalation from the size breath you're creating. So every breath you guys take has a different peak inspiratory pressure, right? If you go, you can get a lot higher, right? If you go small, right? But they both have a peak inspiratory pressure, all right? So every time you look at that number, that's why it's outlined, because it's only created by the size of your breath. So if you wanted to change that, you would need to either reduce your tidal volume or raise your tidal volume, right? If I want more pressure, I go higher. If I want less pressure, I go lower, okay? PEEP, we default to 5, right? You guys are familiar with PEEP, right? Peak end expiratory pressure. It's the amount of air left in your lungs at exhalation. Think balloons. You blow up balloons for your kid's birthday party, right? Balloon flies out of your mouth, right? Now you got to pick it up, try to start it again. That's why we have PEEP. The hardest part about getting a balloon started the hardest part about blowing up a balloon is getting it started, right? So that's why you have PEEP. PEEP is a brilliant tool, right? It will help you in oxygenation, your peak, SpO2, desat events, right? You want to look at PEEP. It's funny how I see people with their bag valve mask, they have no problem turning it from 5 to 10. Great, let's go PEEP of 10, right? But everyone's afraid to press the button and change from 5 to 10, as if this is less accurate than your PEEP valves on your bags. Okay? Those PEEP valves on your bags are guesstimates, right? They are a set number that's based on a few other factors of what's going right. This will provide you with a PEEP of 5 every time, and you will see it. You will see where your patient is trending, right? This will also tell you if your patient has a pneumo. Did I create a tension pneumo? Do I have a PEEP leak? Things like that, because you will see this drop below the PEEP baseline, right? Another reason why we want to use ventilators, because we get information back in those 2, 3, 4, 5 minutes, right? So you can go from 5 to 30, big delta. Another reason why we want to use ventilators, right? If you're open to playing around a little bit, you can tweak some things and try to turn some corners, okay? We know that PEEP adds more pressure into our lungs, right? So you guys, if you look at this, right, you look at my test lung here, PEEP of 5, okay, great, you see it, right? If I change this to a PEEP of, and I'm just gonna go up to 15 so we can see some drastic change. When I go here, you see how much air stays in this lung, right? Now I'm gonna tell you again, I only got 3 minutes to the hospital. My PEEP valve's at 10, because my SpO2 is a little low, so I'm going. This is at 450 mils of tidal volume. If you notice, see where my pressures are going. I'm already at a high airway pressure from a safety perspective. And what was that? 5 breaths? You're trying to give at least 12 in a minute, right? You continually press that bag and not monitor what you're doing. As you continually or have PEEP like this, you're going to create more intrinsic pressure, even if you're only going from 450 to 550 to 558 to 670. Those little increments over 3 minutes of time create maybe an extra breath, right? I'm going to turn this down so we don't have to hear the alarm anymore. But question for you, right? If I have extreme pressure within my chest, there we go. If I have extreme pressure in my chest, right? Oh, now we have a new. Is that on your guys' end?
Yeah, I think you just gotta angle it a little bit.
Oh boy. Can we see better? No. Money. So with PEEP, right? Intrinsic pressure. What does intrinsic pressure do to cardiac output, right? A lot of intrinsic pressure, extra PEEP, pressure held in the chest, right? Will start to suppress your vena cava, right? It will do what? Start to drop your cardiac output. Another reason why we use vents. If you're going to play with PEEP, you need to be hyper focused on your patient's systolic BP, right? If systolic BP starts dropping, I should drop off the PEEP, right? You'll be surprised how many people I work with who take blood pressures. They're like, yeah, halfway through the call, all of a sudden my systolic BP started dropping, and they're trying to figure out why and this and that. And I ask them, well, how are you ventilating the patient? Well, we had him on the bag. Did you have a PEEP valve on it? Yeah. Did you have it on? Yeah. Right. Over time, that pressure will start to suppress your patient's vena cava, drop their systolic. So most of my departments usually have a trend of, if it's trending towards 90, you're off the PEEP. If your systolic hits 90, you get off the PEEP. That's what a lot of my surrounding departments have. Okay. But one of the things, again, just the importance, I want you guys to understand that your bags go 5 to 10. These go 5 to 6, 6 to 7, 7 to 8, so on and so forth. Right? Maybe 10's a lot. Why not go 5 to 7? Let's give them 3 breaths. Oh, my SpO2 went up from 88 to 90. All right. Let me crank it up to 8. Oh, wow, I'm at 91, right? All of a sudden, over a 3-minute period, your patient's at 94%, right? Just because you put them at a 7 a PEEP, as opposed to going from 5 to 10 and trying to play that game. Make sense to everyone? Questions, concerns, issues? All right, that's the first reason I like that box. Second reason is the 35 and 10. Those are alarm parameters, right? So if I'm new, I haven't used these devices, right? I show up, I say, oh, I looked at the guy and I looked at the wrong column. I thought I was looking at the 6 foot column. I looked at the 7 foot column, right? So I put 860 mils of tidal volume into this guy, right? Let's blow out his lungs. What I want you to notice is, if you look at my alarm, it's at 35. You see I'm blinking at 35. Look at my waveform. Where does it stop? At 35. That number is also a governor. So if that number says 35, the device is basically going to tell you, hey, I will give you as much tidal volume as you've asked for until I reach that peak number. Then I have to drop the patient or flip them into exhale because you told me to. We're protecting the patient's lungs, right? Great for our normal, regular patients, right? How about ARDS patients? I've had ARDS for 5 years, right? Pressures of 35 probably aren't flipping these patients, right? So if I want more pressure, or I want a new governor, right? Maybe I bump this up to 45. Hit the green check, right? Now I just extended my ceiling. Now I have more volume in, so it's still limiting me because I'm putting in too much. But even at 860, it's saying, okay, I'll give you 10 more. But once you get to 45, I'm stopping you again, all right? Provider safety. If you guys are not moving that number, you should be confident that the device is not just going to allow you to take somebody out of the game, okay? Now, again, are you going to have to move that number in some cases? I mean, I think that is I think that's up for debate depending on some factors, right? How far away from the hospital am I? What is this patient actually doing, right? Do I feel comfortable in doing that, right? And that's fine. You don't have to move that every time. The only thing I want you to take from that is that there is something in the back end protecting you if you decide that you need to make some changes to try to flip your patient over, right? If you want to add a little bit of extra PEEP, if you want to increase their tidal volume a little bit, right? These are things you can do, and they should not result in catastrophic patient issues. You know, the alarms here are set to protect you and the patient. Okay, questions, concerns, issues about that? Everyone good? FiO2, 21% to 100, single digit increments, right? It's another thing why I like ventilators, right? Most of the time, if you're not using a ventilator, you're using a bag and you're just flowing oxygen in, it's 100% FiO2 most of the time, right? You're just saturating patient's oxygen. Okay, I go back to like that COPD patient, right? They probably walk around at what, 89, 90? Do they need 100% FiO2? You're just gassing these patients for the sake of gassing them, right? When in reality, maybe, they're probably sitting good at 40, 45, right? If you're on scene and you see your patient's sats are trending the right way, well, great. If I could say a sat of 94 at 60% FiO2, I would rather be there than 100%, right? And so it gives you that ability. I'd rather be at 98% than 100, right? Every little bit helps, especially, we don't have to get into free radicals and this and that. We're not going to. You guys know why, right? So these are just little things that I'm just trying to trigger in your brain. And it is do I have the time to do it, right? I talk about using these during cardiac arrest, and some people look at me and I go, hey, I'm not telling you that when you show up to a code, the first thing you do is grab the airway bag. Go hop on the chest, do your normal thing. If a chase car shows up and you can say, hey, chief, can you go grab the ventilator out of the rig? That ventilator will better support the patient than you would. Kind of the same way with these, when we talk about these principles, right? Is the ventilator supposed to be your number one thought process? Let it trump everything you do? No, of course not. But I think, you get sedation on board, right, and your patient's chilling out for a second, you could probably take a second to go, you know what, why don't I just pull a circuit out, connect it, right? If you're using FiO2 or you're using saturated oxygen, it will tell you based on your breaths per minute, everything you've got going, your O2 usage, right? More so just for portable tanks, right? Any questions about what you have seen right there, right? I like to reiterate this. When you guys do calls, there are a few things. If I was you and I was running a call, right, I would tell you, you'll probably press this many buttons, right? I like to show people this little order of operations because I feel like when they see it, they're like, you know what, I could probably do this a little bit more, okay? So again, patient's intubated, so I select adult. I connect, all right? Device is breathing on its own, so I don't have to worry. Patient's safe, right? I look at my end tidal. End tidal seems high. Perfect. I'm going to for sure move this, right? So let's just say, end tidal, move this. End tidal looks high. One change, right? I up their breaths per minute. Nothing new to you guys. You know that, right? Ideal body weight. Patients look like they're 6 foot. Great. Up to 500. You guys already do that today. Simple, right? You'll probably move FiO2 because you'll probably start, I'm assuming it started at 100, work your way down. Okay, so, excuse me, I'm not going to change it so we don't get the alarm, but 100%, that's 3. Okay, from there, you might change your PEEP. You might manipulate a few things, but you see, I mean, I think even teaching it to you guys, it took, what, a minute? Turn it on, connect it. Great, my patient's end tidal's high. Let's give them more breaths. They need some saturated oxygen. Great, change the tidal volume. Then go. That little bit, 1 extra minute, and then go. Right? Now, if you get stuck in the hospital, if you get stuck in traffic, if you're sitting in the hallway, if you're doing any of these things, it's not on you. So, ouch. So again, just those little things, right? Now that you feel confident in using this, or at least doing that part, now's when you can sit back and you can go, you know what, Jimmy has COPD. Let me move his IDE ratio, because everyone in here knows that COPDers exhale longer, right? You don't have to be a respiratory therapist to work this. So we're back. This is how I got it set up. We pressed a few buttons. We got going. Okay. Now let's talk about the long holds, right? So a couple things. This will deal more with non-invasive ventilation, but it's much easier for me to show you how it works invasively. So I want to make sure everyone knows what I'm going to show you now. You will press when your patient is breathing on their own, but I don't have to do anything with the lung if I do it now. Okay. So trigger sensitivity. How many people, when they put patients on this non-invasively, change the trigger sensitivity? Told to. You do every time. Great. If you don't, I would say there's probably a 60% chance your patient is breathing under or breathing in the mask and the vent is not giving them air. And it's because they're not strong enough to trigger, right? So if you look down here, trigger sensitivity, -2, it says -2.0. That's a negative pressure. Your patient has to be able to go to say, I want a breath, right? That's why when I tell you on invasive, if you see that number change in the breaths per minute, it means your patient is breathing. That didn't happen because you hit a curb. They went and took a breath, right? Well, in non-invasive ventilation, most of the time your patients can't do that. If they could, they wouldn't be calling you, right? So think firearms, right? Trigger sensitivity, okay? You have a firearm, it's loaded, you pull the slide back, hammer stays back, hairpin trigger, right? You can rattle off the whole magazine in seconds if you want. Boop, 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 barely touch it, good, right? If you decide, oh, you know what? False alarm, I'm gonna put this thing back in my holster. What do? You drop the hammer, you put it back down. Why? Because you store it that way because it takes more pounds of pressure to fire the gun, correct? Same thought process with this device, right? At least you didn't lose the whole thing. How sad would that have been? Same principles. So right now, when you show up, think about this device. I would have your mind think about this. When you show up, if you do not change it, the hammer is down, right? It is in a safety mode. We want our patients, we need them to breathe or be stronger, right? I would also implore you to think that most of the patients that you are dealing with or showing up to, they need a hairpin trigger. When you show up and they're doing this one, they need the device to go, oh, that's you. Great. That wasn't a bump in the road. That wasn't, the provider hitting the circuit with the elbow. That was you going, please, right? So you can lower their trigger. Again, we'll default this. So when you guys show up non-invasively, you won't have to do this, but I'm showing you right now because, yeah, you will not have to do it. You'll show up, you'll go down to custom, you'll press the green check. This will all be here. But it's important for you to understand why is it changed that way, right? The kind of the convolution, right? Make you press less buttons, but I want to make sure that you're not leaving without understanding why did we even change it, okay? So to do that, trigger, it's a negative pressure. So we would hold the pressure button, the PIP button, right? And when we do that, our trigger level menu comes up. Closer to 0, easier to breathe, right? So -2, -1, -0.5, easier. -3, 4, 5, 6, much harder. Okay? At negative 0.5, you hit a curb on the way out, your patient's getting a breath, probably 2. All right? At negative 6, if you do a compression on their chest, there's a chance they don't get a breath or trigger a breath, right? That's how far the delta is. I would say negative 0.5 is a non-moving, right? If anyone ever showed up to a lift assist where you look at a person sitting in this recliner going, I can't believe you're still conscious, right? Perfect example of someone who probably needs the negative 0.5. If you move them, you probably use enough energy just to pass out. So you're like, you just need to sit here for a second while we talk about what the hell we're going to do with you. I would put them on negative 0.5. That would be a recommendation from, or not, excuse me, not a recommendation from me, but my other departments will put them on negative 0.5, let them sit there, and they're going to, because they're not moving, they're controlling everything, right? If you were to put that patient in the gurney, you put them in the power cot and you want to move them, you need to up it back to negative 1, or they're going to get breaths, right? You don't want to jam 6 or 7 breaths down someone's throat as we gain some traction, right? So sweet spot is negative 1, right? Just think about this. It starts at negative 2. So if I started at negative 1, what did I just do for them without doing anything? I cut their work of breathing in half. Isn't that what we want to do for our non-invasive patients? Make sure they can do as little work as possible, but properly oxygenate them. So you show up. So again, you guys won't have to do this, but when you show up and you go down to custom, you hit the green check and you hand that patient a mask, from where the default setting was, you've already made it half or twice as easy for them to breathe. You've cut their work of breathing in half, right? So that's the first thing. Does everyone understand that? Does that make sense, everybody? Okay. Disregard what I'm about to do. I need to put this into pressure so I can show you the next thing. You guys don't ventilate in pressure, so this is like if you were at a show, this is an intermission, just only for entertainment only. Okay. So now we're in pressure. I do think it's important though for you guys to understand this next non-invasive concept. So we had trigger. Very easy. Triggers at negative 2. I want to make it easier for my patient to breathe, right? Your COVID patients, your tachypnic patients, the tripodders who are sweating, they got the pursed lips, they got the neck roll, and they're doing the right faster or lower trigger, easier for them to breathe, right? Now this is the second kind of workup of our breath, right? Has anyone heard the concept of rise time? We all know what rise time is. I'm assuming there's some understanding of that. Make it very easy for you. Everyone in here has a different rise time right now. We're all breathing differently, right? If you just came up the stairs, you probably breathe a little bit faster, right? You all do physicals annually, right? When you hop off the treadmill, fast rise time. Tachypnic breathers, your 40 breaths a minute. The COVID patient, fast rise time. If you just get done at yoga, right? Wife, significant other drags you to yoga. You're in the middle of yoga. You're finding your zen, right? Slow rise time, right? You show up to those patients that are like mid-overdose, somehow still breathing. Slow rise time, right? Find the guy in the bus stop, standing like this, somehow still breathing. Slow rise time, right? You can manipulate this. Rise time is the speed at which you go from the peak baseline to your peak inspiratory pressure. Basically, how fast do you want the air, right? It's like if you showed up and you said, Jason, you're in respiratory distress. Do you want it slow or fast? And I go, well, I can't breathe, so I want it quick. Thank you. That's basically what you're figuring out, right? So again, your tachypnic breathers, just think about what you're seeing. If your patient's tachypnic, they're going to need a faster rise time, right? This is a rise time of 2. The fastest rise time is 1. They have no time connected to them. It's not 1 second versus 10 seconds. Just think 1 is very fast, 10 is the slowest. All right? It's like a pain scale, 1 to 10. How do you feel? Okay. 1 fastest, 10 slowest. But to give you an idea, this is kind of probably similar to your tachypnic breathers in terms of how quick they want the air, right? They're obviously breathing a lot faster than 18 times a minute, but this is how quick they want the air, right? To change rise time, it's a function of the breath. So our other hold we did was pressure for trigger, right? Rise time, function of the breath. So if I hold breath per minute, this little menu comes up, right? Again, this will be already defaulted for you in custom, so you won't have to do this. But you go down to rise time, and what I'm going to do is I'm going to show you guys what it looks like. So right now this is 2, very fast, right? Let's see what 5 looks like. You see that waveform? You can hear the change. right? So our COPD patients, do you think they prefer the first one or the second one? Second one, right? If they're breathing on their own, not in distress, they're just walking around daily, they would prefer the second one, right? They want to control how much volume is coming in. They don't want to have all that volume jammed down their throat, right? So things to think about just in terms of when you're thinking about patients that you've worked with previously, like, maybe they needed a little bit of change here, a little bit of change there. Now, the reality of the situation is, I'd say 89% of the patients you guys show up to, like, right, the respiratory distress call, they're breathing fast usually, right? 35, 40 times a minute. You're trying to figure out, how do I get them down before I have to tube them, right? So you will play most likely in the faster rise times. That's why we'll default yours to be faster so you don't have to worry about it, right? The emergent response type of setting. But it is important for you to think, if you have a patient who's breathing on their own and you're starting to turn the corner, right? You did all this work. You got drugs on board, right? We did the bronchodilators. We gave them a little happy hour cocktail. All of a sudden, they're hanging out. You're like, man, this is going great, right? There is a spot where this becomes too fast, right? Where they go, hey, I'm feeling better, right? Think about this patient can have an anxiety attack. You're like, hey, I need you to breathe. I need you to breathe. What you're telling them is, I need you to slow down your rise time, right? You guys already know these things. You tell people to do it every day. Take deeper breaths for me. Try to take a big, deep breath, AKA slow down your rise time, right? More air you can take in, what does that do? Passes more to the lower airway, expands our alveolar surface area, creates better room for gas exchange, allows them to blow more gas off, right? So again, you guys are already familiar with rise time. Now that I probably tell you, you're like, I guess I do think about it all the time. That's why it's in the ventilator. So we will default it for you. But again, 1, fast, right? To get the breathers, right? 10, slow. Never go to 10, right? I think 5 is like what I would call in the realm of slow, right? 3 is pretty normal, all right? We good with that? Okay. Anyone use the plateau pressure button? You guys have plateau pressure on yours? No? Okay, perfect. We'll stay out of it. So that is invasive ventilation in a nutshell, right? We talked about, I think, 2 concepts you guys were maybe quote unquote unfamiliar with, right? Trigger, rise time. You're familiar with them. Rise time, and neither of them you'll really need to use an invasive because you're driving the ship, right? So this next piece, the non-invasive, and if you want to talk convolution, right? This is where we can set you up in the custom settings, right? But this is where it does take a little bit of understanding from your brains on moving some things, right? So I think I'm going to show you a couple of things. I'm going to show you what rise time looks like I'm going to change these things to show you what the breath looks like differently, how it responds. We'll talk about a few things, and then we'll go from there. If you have questions or concerns, this is probably where most questions come up, because I think this is where most people get the biggest issues with the vent, right? If you sedate a person correctly, more than likely you're driving the ship. You shouldn't have any issues, okay? You can get all the right sedation on board with this, the proper drugs for a patient non-invasively, and still, based on what they're going through, have to move some things, right? So first thing I want to show you, improper way to do it, right? And again, not calling anyone out. This happens in every time I do these, every single time. And it's probably on me because I'm the one who deployed them, right? So we'll take a little look in the mirror, right? So if I go to adult, and then I go down to let's just go to CPAP here, all right? You see that? Oh, we're still angled. Okay. You look down the right-hand side. You guys see those alarms. 35, 10, 675, 225, 25, 8, Ghostbusters on your leak comp, right? This is like the homicidal settings to have a good experience with this ventilator non-invasively, right? Now it doesn't mean you couldn't use it. It's still gonna operate the same. The difference is you would be pressing probably 8 different buttons before it was back to what I call square one if you just went in the right way. And 90% of them are alarm based. Okay, so just take a mental note of that, because when I come in here, so if you find yourself doing that, if you look and you're like, oh, I know those shouldn't be there, treat it like a Super Nintendo. Turn it off and back on. Okay. Doesn't have the timeout like the X series or anything like that. You don't have to wait 3 minutes. I mean, you can just flip this bad boy, boom, boom. Sorry, Susie, didn't mean to do that. You know, long night. I'm about to get off shift, whatever the case may be. So it comes up. Can we still see that? Good. I'm like leaning over here. So if I go down to mass CPAP first, look at those alarms. So we have one, a lower high pressure alarm. Why? Because our patient's breathing on their own. We don't want them to breathe themselves into an output issue, right? Tidal volume off. Why? Patients breathing on their own. Nobody gives a damn if it's 300 mils or 600 mils. You're breathing, awesome, right? Whereas in the other mode, if they take a 250 mil tidal volume breath, the device is going low tidal volume. You're thinking, oh, my patient's dying. No, they're not. They're breathing. So off, right? Look down to your breaths per minute. Your high alarm before was 40 or was 25. This one's 40. So now it's not even going to scream at you unless your patient breathes. Slow rise time. This call right here, Pursuit. This is like the ideal ventilation call. They're gonna have a bunch of trauma. You're gonna need to get on, deal with a bunch of stuff. Tube the guy first, put the vent on, let him sit on the side, figure out the rest. Ask him when they came back what they did. Yeah, I mean, just give him the nose and send him on his way. So you guys see those alarms, right? 40, and then notice your leak comp is defaulted to on, right? Leak comp defaulted to on. Huge, because again, big beards, right? What mask are you using?
Every time I do large, it's a problem.
Is it a Zoll mask?
Yeah.
Okay, we'll talk about that post-recording. So that's just a patient disconnect alarm because I'm not breathing. So let me breathe real quick. So as you see, these are our standard alarms. This is what I would call correct, right? Again, we don't care if they're breathing 25 times a minute. If my patient's breathing 40 times a minute, sure, I want to know. In your case, maybe you guys decide, hey, I'd rather just not hear the alarm at all. When people tell me I hate my high breath rate alarm, it's so funny. I look at them and I go, okay, well then just do this. And just get it out of the way. Now it's at 77. Okay, your patient will be unconscious before the device tells you that they need to breathe more or that they're breathing too fast, right? You can turn it up to 100 if you wanted. It's up to your department, obviously, but you can manipulate that. So if you guys just say, I don't need that to even be in the mix, turn it up to 100, keep it moving. You don't have to even worry about it at all, right? So there's one alarm you can totally take out of play, okay? The other one, if you get a PEEP leak alarm, which you've probably gotten, right? So PEEP leak, it means the device notices a breath that goes below the PEEP baseline 2 times in a row. Very common if you have a big mask leak, right? Because they're noticing this drop, okay? PEEP leak is an alarm you can turn off. If you were to trigger it, you can hit the menu button, right? Alarm config. You see PEEP leak on the screen. If I had triggered it, oh shoot. If I had triggered it, there we go. I'm trying to find the middle here. Cool. If I had triggered that alarm, let me breathe again, it would give me the option to turn it off. So if you get a PEEP leak, turn it off. If you don't want to hear about it, turn it off. Go.
Question I had, so like that last one that just went off.
Apnea.
So, if you turn down, like you said, your trigger time. So I see the really, really low lights. If you turn down the trigger time, would that kick out that alarm? Like the cat is still breathing, but it wasn't the machine actually kicking out.
Yeah, so what the guy was doing was he was breathing. So your guy had a mask on, right? You were getting apnea backup, and he was still there. You're like, what the hell is going on? He's breathing. The device is saying that's not a breath. It's too strong for him.
Okay.
So had you turned it down, those little he was making, the device would have said, oh, that's my patient. That's not someone doing this. So that will happen a lot of times, right? I call that suffocation protocol, is what that is. When you mask, so, and you know, because eventually what happens is that they start grabbing at the mask because they're thinking, why am I not getting air? And you're hearing the device go and you're going, what the hell? It's a mixture of the device doing what it's supposed to, but what it's supposed to be doing is not right for the patient in that moment. So had you been in the default settings that we'd leave you with, or when those get set, more than likely at -1, he's going to be able to trigger that. And from there, you start asking yourself, if he can't, do I put him down to 0.5? Is that going to create an issue for me? Because -0.5, you can just get multiple breaths coming in, right? So again, right now, you guys see, I mean, I had to put some effort in to trigger this, right? This is just trigger, -2, normal, right? So we said the first thing we would do, or I told you the thing that would be good to do would be to turn their trigger down, right? So if I go in here, I turn it down to -1, right? So all we've done is change the trigger, all right? Now when I do this, see I'm getting a little breath, little small, looks like 145. If I gave it a good little push, right, I could probably get up to the 200s. If I yanked it, I could get up there, right? So again, though, my patient breathing very easy. I'm just tapping it and they're breathing. Okay, perfect. So then let's change our pressure support. You guys manipulate pressure support, PEEP, things like that. All right, so anyone ever heard a patient say to you, oh, it's too much? Things were going well, felt like it was good for the first minute, minute and a half, and all of a sudden it turns into, it's too much, right? Telltale sign of not too much as in too much air. All your patients are liars. They don't know what's good for them. Not too much air. They're probably saying, I feel full, too much, right? So again, let's look at it like this, right? If I was to change, let's just say, if I had an SpO2 of 84 when I showed up, right? You guys would go, okay, great. We crank them up to 100% FiO2. We're up to 88. I like that. We want to get higher, right? We still need to try to get higher. So you guys move the PEEP up. We're at PEEP of 5, right? I go to a PEEP of 10. I hear you. Almost caught it. So now I go to a PEEP of 10. Great, right? So I'm at a PEEP of 10. I look at my SpO2. We're at 92, right? So we see more air is left to my lungs. So I'm triggering this small breath, holding air in my lungs. I'm getting better oxygenation, right? So my patient's doing less work. I'm getting better oxygenation, but I'm at 92 and I'm like, man, I need more. So you guys decide, hey, my systolic still looks good. I'm gonna crank it up a little bit more. So all of a sudden you decide that you're gonna go to 15, right? So I go here, I go up to 15, and all of a sudden now at 15, these little breaths, right? When you see that air that's okay, great. My patient's at 94. Oh, this is awesome. I reached the top, 94. One thing I don't have to worry about. Another minute goes by and they start doing the, it's too much. It's uncomfortable, right? Well, again, let's just use our brains. If I did this 12 times in a minute and continued to hold this much air, over time, I'm eventually going to fill up, correct? Like, over time, you're going to feel that kind of burning sensation, right? I mean, you understand where we're going with this. So maybe from there, this is when I start looking at, when I say, why do we use ventilators? Move some things in tandem, right? Maybe instead of 0 and 15, I say, oh, that's too much PEEP. So look, I'm going to drop back. Maybe I do this. And this is just things I want you guys to think about. This is not there's no right or wrong perfect way, right? But maybe I drop the PEEP to 12. And since I was at 15, I'm going to bring my pressure support up to 3. Okay, so now watch my breath, watch my tidal volume, all that. So I trigger a breath, but see now, just by me pressing my finger, you see my tidal volume, 288. I'm getting almost a full-size breath for a 5'10" average male. Great. Oh, it's still too much, right? We're talking to our patient. It still feels like too much? Okay, perfect. I'm going to drop my PEEP back down to 10. I dropped it down 2 more, right? Why don't I bump this up? If I'm going to take some out, let me make sure that we still get some in, right? So now I'm getting, again, higher tidal volumes, lower PEEP, so I'm getting more air, right? I'm triggering more breaths just But I'm getting more air here. So air's coming in. We're helping it get down to the lower airway, exchanging it. Now they're holding less in. Why? Because we're oxygenated better, right? We're at 94 already. So I know my body, I know the patient's body is obviously moving gas. You know, this is all assuming that we're looking at our numbers and going, great. They're obviously exchanging gas. So we're continuing to move down this line, right? But you see how we're still giving them that same relief, but we're taking some things away, right? How we're moving it. These are the things that you can't do with the bag. Now, again, your default settings. When you show up emergently, I would probably say your patient's going to need, higher. I mean, they could probably maybe higher peeps. You might want to take it to a 12/7, 13/7 type of default setting, right? But again, when you guys show up, you go down to custom, you hit the green check. Wouldn't it be so much easier if all that was already set for you? Where it just starts you in a emergent mode, and from there you're moving things based on how your patient's responding, right? So we've only moved two things here, which is we changed our trigger so they could breathe easier, and then we manipulated PEEP and pressure support, all things you guys are used to, right? The only thing that we haven't done yet is the rise time, right? And again, this would be defaulted for you, but if it's at 1, which is the fastest that we have, when you look at the waveform, so now you see these size breaths I'm able to make. If I'm that patient that all of a sudden I take that one big pull that I want, I'm giving them an option. They can take a 600 mil breath if they want. If they go, oh, you know what, I'm still tired. Well, we can at least get them 300 by doing nothing. And it's 300 fast, right? So if they're going, most of you probably never seen this thing work like that without it alarming immediately, right? PEEP leak alarm. We could turn that off if we wanted. Now, there is one other thing in here. I think you're shocked to see this be able to go that long without an alarm. Yeah. So the PEEP leak alarm, right? I just triggered it. I told you guys you could turn it off. So now, alarm config, PEEP leak, off. Now it's off for the whole call. So now you can't hear it. So like uncuffed trach or something like that where gas just blowing, I don't want to hear it. The device gives you options. If you don't want to hear it, turn it off. You just have to. So again, they're breathing. All right, so now that you see that the device can actually work without screaming, if you move some things, right, that should give you a little bit of confidence. 2, I just want to also make sure that you guys don't shy away if you need to from pressure support, because that pressure support, if you let them make the effort, they can get a full breath. Right, so I'm just tap this, 400 mils tidal volume. Right, as opposed to me having to go, right, just. So that's the difference, right? Now there's one other thing in here that I will show you called spontaneous TI limit, or excuse me, cycle off percentage. We all have a cycle off percentage. This is a concept you guys know. You probably use it a little bit, but so inverse number, right? We all cycle off. So cycling off is when you decide, or your body subconsciously decides, I don't need to inhale anymore. Okay? So again, in yoga, right? You cycle off late, right? If you get off the treadmill, your body's saying, breathe, cycle, breathe, cycle. Why? Gas, gas, gas. Let me cycle into exhalation, okay? When this says 25%, the device inherently, the way it's built, it wants to hold your patient in inhalation. AKA, it means I want you to get to 75% of your max PIP. So if I go, and let's just for adding purposes say my max PIP was something easily divided by 4, 20. Okay, well, I'm like, I'm actually good. My max PIP was 20, right? The device basically says you need to get to a PIP of 15 at least before I open up your exhalation valve. Now the patient can force it open, which is what you see when I go like this. When you hear the little delay, when I go, there we go. You see when I push and you hear that little delay, right? That's the device, because I didn't reach max PIP, and so that's the device saying, oh, and I'm forcing I'm forcing it open, right? Which in a lot of times doesn't matter. But again, let's use our COPD patients. Do they breathe like this? Or do they breathe? Inhale quick, exhale slow, right? So if this device wants to hold them into 75% inhalation, how many of our patients do we really think could even get there? Not many, right? So when you change that number, it just tells the device that, hey, if your patient wants to exhale quicker, they can. It does not make them. But let's say I change it to 50. Well, now if I get halfway, the device goes, great, you want to exhale? Go ahead, right? Now just, again, we don't all have to be math majors. Well, let's just do a little bit of math here so you can understand, wrap your head around, oh, that makes sense. 40 breaths a minute. One breath every 1.15 seconds or something, right? Something insane. Okay, so 1.15 seconds for a whole breath. Okay, let's just put that there. Now, if I'm a COPD patient and I need 4 times as long to exhale, now I'm dividing that 1.15 into fourths. So now we're at like a quarter second, right? The point is there's not enough time in there for your patient to even reach the numbers that are set if they're breathing that fast, right? You have to give them or manipulate the parameters to allow them to achieve what you want, right? And does that make sense to people, right? If you just look at it from a mathematical standpoint, damn, there's not enough time for them to even work out. So if you change, and it's just something to think about, and you change this, and I'm just going to bump it up, like I said, maybe 50, 55 even. So now this means if my patient gets up to 45% of their max inhalation, so all they have to do is get almost halfway up the ramp, and the device goes, great, if you want to fall off the edge, feel free, right? That's how I would describe it to you. It'd be like you're on the roller coaster, you're kink, 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 and halfway up it says, hey, if you want to get off this ride because you're scared, off the side you go. Same thing, right? So now when I try to breathe faster on this, see how, I can, what is that? Oh, high probably. Yeah. So, and it's because I have all this pressure support and PEEP and everything, but you see how we can get the device moving because I'm reaching those little parts where everything's working in congruencies. Make sense to people? So like, am I telling you, hey, you're going to have to change that every time? No. But if you're out there and you're like, hey, you know what? I've changed my rise time, or I went into custom, my trigger, everything was set how it was supposed to be. And maybe I'm looking to make the patient a little bit more comfortable. That might be somewhere I go. I'd look and go, okay, let me move that a little bit. Let me see if it helps them to be able to flip off their breath a little bit quicker. Because a lot of times what happens is they just are already exhaling while the device is still finishing their breath, right? So imagine put your car out or put your head out of the window when you're going up the freeway. That's what they're experiencing when they're exhaling against air coming in, right? Put your mouth around a leaf blower, however you want to describe it. That is the sensation you're giving them, right? So, had anyone put a patient on this device? Well, first, does that make sense to everyone? And I mean, realistically, is anyone confused? Do people feel better now than they did before? Okay. Has anyone used this device and either had a patient go apneic and have to take their airway or anything in that regards? Or okay, so what I will tell you is this is one of those devices where if patients go apneic or you feel like you're going to take an airway or anything like that, I feel like people are very quick to want to rip these things off, right? Because they're like, I need access to the cords. I got to get down there, right? I would ask that you take a step back and perhaps not do that, right? I'm the patient. I have a mask on. I go apneic, right? Device is already breathing for me. Why am I going to have you rip the mask off just to grab a bag to start bagging them? The device is already breathing. I'm breathing for him, right? What I would say is, hey, we're going to take this patient's airway. Great. This is no different really than low flowing a nasal cannula or something, right? We're getting passive oxygenation. Grab your intubation kit. Okay, great. You grab the intubation kit. The moment you tell me you're ready for the cords, then I'll disconnect, flip this off, back on, and I'll hit adult. I'll be ready for the patient well before you're done intubating. And so now we've continually oxygenated the patient. So when you go to intubate, they have oxygen on board. They've exchanged some gas. If something goes south, they're probably more physiologically ready to be resuscitated, right? As opposed to you putting them on this, going through all that effort just to take them off, to put a bag on, to give them however many breaths you need of stuff that just didn't go right. Last thing I'll show you on this is you can manipulate the apnea backup setting. So not many, I don't want to say not many people do, but it's not something that I have people prioritize. And I have no problem with that.
When they went apneic, it just started breathing.
Changes on their own. So it defaults to assist control pressure, a pressure of 20, 12 breaths per minute, 1 to 3 ID ratio. So it basically just takes them to exactly where we are when we select adult. It's a lung protective setting. It's lung protective, and it just continually will make sure that your patient does not end up hurt, barotraumas, things like that. Not going to have them turn any corners, right? So if it's like, if you're just in the midst of intubation, it's fine, right? Oxygenate them, great. Pull off, let them do whatever. But if I was like on a longer transport, right, and I had this patient, and we were trying not to intubate them, right? They're going in and out of apnea. ARDS patient's a good example, right? What I would do is if you hold the mode button here, when they're in a non-invasive mode, it pulls up that menu. That's your apnea backup menu. So I could change any of these, right? So I'll just change one, and we'll do breaths per minute, right? Let's just say that I'm looking at this patient right now, and their end tidal is at, 68. So I'm like, if this patient right now, they're breathing about 20 times a minute. So if they go apneic, I want to do the same thing, right? We let them go apneic. What the device will do now is, instead of going back to the default 12 breaths, all that, it's going to go to whatever we put in. So it'll start supporting the patient based on what we've changed it to. And should they decide, which follows the prompt, should they decide, let's say they just took this off and they were like, oh, that's fine, triggered a breath. If they were like, oh, you know what, they went to intubate but didn't turn the device off and on, just forgot that step, that's fine. The device, when it's in apnea backup, will say, the last one says set mode to assist control or whatever. Select mode, set BPM and tidal volume, apnea, the whole nine, right? So I go over to assist control like it says. And now I'm at a PIP of 20, 22 breaths per minute, right? So even then, I just changed from invasive or non-invasive, went to invasive mode, and it stayed. The only difference is it drops you automatically into pressure. So for like your guys who are used to working in volume, this would be nice because they'd get back to it, but then they'd be like, oh shit, there's some stuff going on. So that's why I always try to tell people, if you can turn it off and back on, it's quicker, less things for you to think about. They're going to still be intubating. Super simple. Yeah.
He's got it written down too. I got a question. So as far as like if we're going in invasive and like we've got somebody that's CPR and we've got an eye gel in, we don't have a tube. How is that machine handling that?
We're validated with eye gels, and they look great. Drop an eye gel and throw it on like nothing, no difference. Yeah, eye gels are fine. Some of the things I think are important, right? Like nebs, right? You're administering nebs. You guys have white T nebs. I get blue ones. Blue ones have a spring in them. So if you put the T neb in line, today, if you pull that cup out, it opens up the circuit, you lose recruitment. So you put the bronchodilator on, you've got everything down the alveoli, you've gained gas exchange, you're moving. The moment you pull it out, it opens the circuit, you lose all of that. No one clamps tubes anymore. But that's what you would need. You would want to, the fail-safe would be, hey, clamp the tube, put another one in. None of you are going to clamp a tube. If you get the blue one, you pull it out, it springs and shuts the circuit. when you put the second dose in, it opens the circuit back up. So your patient can continually breathe on their own and continue to exchange gas. And you can put multiple doses of bronchodilators and things on board without getting reset every time. So that would be something I would look at. Yeah, I mean, I don't think they're even a change in expense. If so, it's very minimal. But that will help you from that standpoint of being to administer drugs, right? I'd also say don't shy away from your drug box. I say this every time I stand in front of you guys, but everybody likes a happy hour cocktail. It is what it is. That's not me saying like, hey, you need to snow everyone. I don't advocate for that, but most of the time, just something to take the edge off, so people will even listen to you. If you're breathing 45 times a minute, there's not many things you're going to be able to do from a ventilatory standpoint that are going to immediately calm that down, right? Now, if you got that down to 35 or 30, much easier to work with, right? So whatever you use, whether I don't know if it's Versed, ketamine, or whatever your protocoled medication is, I would just say don't shy away from it, and I would do it on initial onset.
Yeah, it's rare. I mean, I've come across a couple times we have to give them benzo because they are anxious beyond totally hypnic, COPD, or heart failure.
Yeah. And so what I would tell you, right, is like those ones that's like the super, like, okay, I gotta get something on board. This person's really losing it, right? I would tell you, if you have in mind or have previously dosed a patient where they are not that, hypersensitive, but you could put something on and not ruin what they already have going, I would say that as long as your administration is fine with it, it would help your success rate. I mean, it's just like, you're out with your boys, on the streets, you see a pretty girl. Was it easier to talk to them when you're totally sober, or if you put down a couple beers first? I mean, me too. Exactly. At this point, I probably just crumble, right? I've been married for too long now. But you understand what I mean? That courage, right? Is just the idea that, like, you know what, you're just a little bit less aware of what is actually going on, so you can do that, right? And so again, I don't want this thing like, oh, well, the vent guy said we should use more drugs, so here you go. We're just snowing everyone. Yeah, exactly. Hey, I don't want to hear from Kim like, hey, people are just dropping mics of this and doses of that. I don't need any of that. But if you show up, right, and you have the opportunity, it would be something I would think about doing, in reason, right? If you're worried about pneumos, things like that, so just so you guys know how the device would react if you were to create a pneumo, right? So you're going to see an immediate drop in pressure, obviously, right? Peep leak pressure, because the device is going to notice, oh, you have a hole, right? But the telltale actually will be where you get not the immediate drop, but when it goes from the immediate drop into the increasing PIP. Because what's going to happen is they're going to start filling the stomach, filling the chest. And so you see that drop because it goes, oh, it reads this huge drop. And then as your patient's chest cavity begins to fill, it looks like what's normal pressure. And then you start getting airway pressure high alarms. You go, oh, what's going on? You're filling the chest cavity. So if you're looking at it, and I'm not talking about the peep leak where you're going down the road and you still see your guy breathing, and I'm talking about you look at it and you go, okay, something's going on, some other sats drop, and then you see your pressures start to rise. You should think I might have that could be like a sign of attention pneumo. Think about if I took your patient's lungs and put them and stabbed them, and then I put them in a clear Ziploc bag, right? And we were ventilating them. Well, eventually you're going to start to get pressure, and that bag starts to inflate, and then that pressure goes back onto your patient. You'll start seeing a bigger drop in your cardiac output. So when people ask, like, oh, does the device tell me that I have a pneumo, peep leak, then you start to see your pressure rise. So you should see, if you see those in tandem, I would start doing, checking for lung sounds, things like that. Any other questions, concerns, issues? Anyone totally confused? Anyone feel like I can't use this even though this guy just did it?
My question is, I've been doing the
Yeah, I mean, this is just standard connection, so I would just put it. I would put it closest to your patient because to get the best reading, because the more mechanical things you put in the circuit, the more dead space you create, the less accurate I think your reading will get. But yeah, I mean, if you're gonna put the end title in line, it should just be the last piece of stat closest to the mouthpiece.
I just don't remember if it actually adapted.
Oh, I mean, yeah. There should be nothing about the circuit that doesn't fit any of your end title stuff or anything. We're standard size connection for everything, so nothing proprietary. LifePack users and Zoll users who use it currently, so you should be fine with that.
That's not the heart rate and some of the other.
Yeah, so
We don't, but how was that?
So it has an SpO2, obviously SpO2 on the device. It will give you an SpO2, a heart rate, and a pleth waveform on the screen if you had it connected.
How would it connect? Is there like
In the SpO2 thing right here, there is a Massimo. It's just smaller. It's not the rainbow one. It's the one before the rainbow, the smaller one. Your devices are always tracking data, 24 hours of runtime data. So not just a day, but from the time you turn it on, 24 hours of patient usage. Do have the ability to pull that data now. It's a USB to USB. It's not going to be any Bluetooth, anything like it doesn't connect with your X series. There's no press one button.
now I have to in my narrative at the bottom I just document.
So you would continue to do that because the reality of it is I can't leave the software with you to pull it because it's not commercial yet. I have it. How would you guys use it, right? If you had a patient where you're like, that went really well, and you're just like, I want to review it because it exports as a CSV file and it has waveforms. It shows you every alarm that went off, what your settings were. You can timestamp it and drag through and see, at this alarm, what happened. So really biggest part is QA, QI. It would really be if you have a total shitstorm. That not like a death or anything, right? That's probably going to go back to Zoll, and we'll let you work with legal on that to make sure. But if you were like, hey, you know what? I feel like that should have gone better than it did, and you want to go over it, you can reach out to me. I can come on site. We just hook them up to a USB. Okay, I can pull them all, and then you guys can keep them after. So you use them as like continuous training, or if you're gonna do an airway piece for your run review or something, and you want to go over a couple.
But that's something that's coming down the line. You said it's not commercial yet.
Yeah, that's why it's out right now. So we have a few departments like betas across the country who are using it under signed documents that they know it's a beta and giving more of opinion stuff because it still has changes, things like that. There are a few small bugs from a reporting side like that we can work through. But yeah, I mean, the goal obviously will be to have it accessible commercially for all the customers. I would tell you if you're looking to get some type of data, even post-vent, just to make your narrative more in line, I would customize one of your intervention keys to a mechanical ventilator. So when you actually treat it like a drug, you put a patient on it, press it on the monitor, it'll timestamp it in your EPCR. So when you pull your EPCR, you'll have it timestamped when you have it. Yeah. So when you have a timestamp when it went on, so you'll at least have trends. Right, you'll have trends of what happened post ventilation. I think that's its biggest influence is for people and or patient types where we say we don't need to put them on the vent. We're X amount close or whatever the case may be. I think reviewing those and seeing the changes in those few minutes mechanically versus manually are very eye-opening to kind of pushing the narrative of, listen, I understand we don't always have time to do it, but if you're en route, and I mean, I kind of treat it like we talk about things, people usually embellish, right? I'm 2 or 3 minutes from the hospital. I'm like, okay, so you're about 10 minutes from the hospital, right? I'm on scene for about 7 minutes. I'm like, all right, so you got 15, 20 minutes on scene, right? So it's like I hear people are like, we innovate en route, and I'm, by the time I'm done, we're at 2 minutes, and I'm a little iffy on that, right? It's probably more of, we're at least 10 minutes on scene, then we go, then I, move some things. So I assume these patient interactions are probably average between 20 to 30 minutes, unless you're working a code, could be hours, right? But, MVA, traumas, whatever. But I'd say they average about 20, 30 minutes, right? And so in that 20, 30 minutes, I think it's important to figure out how much of the time am I actually supporting this patient's airway. And if it really is 2 minutes, yeah, maybe it doesn't make that big of a difference. But if it's 4, 5, 10, that matters. The only other thing I'll leave you in the non-invasive is when you put a patient on non-invasive, I think it's important for you guys to remember that non-invasive does not always work. And I think that people have this stigma that, like, right, we have CPAP and now we have BiPAP. So if I'm tubing the patient, I must have screwed up, right? I don't subscribe to that way of thinking. I think there is a point where you look and you go, you know what, it's safer for me to have this patient's airway than to allow them to manage it on their own. The waveform is a good help on that. The waveform shows you live in real time how they're actually breathing, right? One of the times I would tell you, like, hey, maybe I should stop non-invasive. If your patient is breathing 30 times a minute still and you're noticing that they're not getting back down to their peak baseline. So they're getting up, but only halfway down, up, halfway down. What does that tell you? They're stacking breaths, right? We know just from our work in hearts and everything you guys go to school for that stacking breaths increases interthoracic pressure, which decreases cardiac output, correct? Very easy way for you to go, you know what? This is trending the wrong way. Do I want to have this patient breathe themselves all the way into a code, or do I want to go ahead and take their airway, manage them properly, get them to a hospital, and let the hospital deal with them? So, again, not telling you to just say, this is going south, so it doesn't look like it's working real well, perfect, so you get a tube. But I think that people are, they move to vents away from disposable, they move to mechanical ventilators, and they think if I'm tubing anyone, I just, I got to go have a look in the mirror, and I just don't think that's a proper way to think. Post-ROSC, post-intubation, I would tell you, if you called me, I'd say every one of those patients should go on a vent. There's not one of them that's going to show up in the hospital and get bagged anywhere. So, emergency medicine obviously is different, but if you have the ability, I would say 100% of your patients post-intubation, post-ROSC on a vent. Questions, concerns, anything I can continue to help you guys with? Do people feel better about it? I know it's a learning experience and it takes a lot of usage, but that's kind of why I tell you, the more you guys use this thing, the better you're going to get with it. If you've got the 4 minutes, pull it out. If the issue is, hey, I use 10 more circuits than we usually use and we need to buy more, I'll give you a box of circuits if it means you're going to use them quicker or use them more. I got more than enough garage space I'm trying to get back, and I get them for free. So you need them, I'll get them to you. But the reality of it is, I think the more times you look at that, you'll use them more. You'll get more comfortable with it, and then you'll start using it in other avenues. Right, you'll start saying, "Oh, I got the COPD patient. They need to go on an event because I can give them all you gotta do is press adult, and I'll give them a 1 to 5 and not touch it. If that's all you did, you're doing that patient a solid."
If we're going to be doing CPAP, should we be putting all that in before we put it on them?
So I would if we do your custom setting, it would already all be there. Yeah. So I use an analogy, right? I always tell people, there's 2 times in your life where first impressions seriously matter. And I say their father-in-laws and non-invasive ventilation are the 2. Because the reality of it is kind of with your guy, right? Give that guy a mask. He puts it on his face. He goes and doesn't feel the breath. You're cooked. He's never going to put it back on. You're the reaper of death. Who are you? I thought you were supposed to help me. You're trying to kill me. These are the things going through their minds, right? So that's the other thing is, don't bane these people. Don't, it's good, and then strap it on them. Hey, how's that feel? Good, bad, okay, mix it again. Good, bad. Let them find something that they will breathe 4 or 5 times in a row without thinking, and I think part of that's where the drugs really help, is where it gives you those 2-3 minutes to go, hey, how's that feel? Instead of, hey, how's it feel? It can be a shit show. So all those things are put in beforehand. So the idea is when you hand them a mask, they should be able to go and feel a full breath. And that'll make them be like, okay, let me give some more effort. Because they have more effort in there. But, you know, you're subconsciously going, I've got 3 minutes left of being able to do this. How do I do that? Right? You start to figure out a way, right? If you walk in and your patient's doing this, they're screaming for PEEP. I'm telling you. I mean, you see a patient like this is PEEP me. Give me PEEP. You should see them and go, okay, they're trying to intrinsically create their own PEEP when they're doing this. Okay? So, like, that's just a visual. If you walk in and you got anyone doing that, they need a little bit more PEEP right out of the gate. Increments of 2s. Live by 2s. 5 to 7, 7 to 9, 9 to 11. If you go 5 to 15, you're going to have yourselves a couple issues on your hands. Not like injuries. You're going to have issues as in patients going, holy hell, right? That's 0 to 100. FiO2, right? 99, 97, 95, right? Start working them down, and you'd be surprised how much longer people will start to tolerate you finagling around with them. So I think the custom settings are big because you get there, it's less time of you guys playing around, less time of the patient trying to figure out whether they like it or not, right? You get them set up from there. I think the only thing that you might change would be like cycle off percentage, right? Just if you really feel like your patient is desynchronous, right? They are trying to exhale with the machine. You can see them, right? You see them exhaling. You hear the device coming in. The mask is kind of coming off the face, that you get that little desynchronous breath. Yeah. They're not matching up with what's going on. That will tell you they're exhaling quicker than the device is wanting them to exhale. Okay. Maybe I move it up a little bit. And then seal is huge.
Last time you came, you had said
Get pulmonites.
we do have those.
Yes.
But you were saying to go with the large over the medium. That's what Thorne thought.
I mean, I don't want to call anyone a liar, but I would hard pressed to throw a size at you. I would say go with, you need multiple sizes is what I would say. My guess would be I said, hey, call your distributor and tell them I need like 5 samples of the best ones you got. And yeah, multiple sizes. They're great because they have the head thing. And those are, that's the mask that I would